My title is Bipolar Disorder with History of Physical Abuse and Comorbid Polycythemia Vera, a case report. Good morning, everybody. My name is Ida Ajukusuma Wardani. I am Sultan Laisong Psychiatry from Indonesia. Today, I will present a challenging case involving bipolar disorder, significant childhood physical abuse, and a rare medical comorbidity, polycythemia vera. Bipolar disorder is highly influenced by biological, psychological, and trauma-related factors. And childhood physical abuse increases risk of early onset, more severe episode, and mixed state and the treatment on response. Polycythemia vera, a myeloproliferative neoplasma, can produce neuropsychiatric manifestation like the fatigue, cognitive slowing, irritability, low energy. And comorbid polycythemia vera and bipolar disorder is rare and post-diagnosis and therapeutic challenging. Consultant liaison psychiatry plays a central role in the integrating trauma background, medical comorbidity, and psychiatry management. And case summary, in women, 20, 30 years old, Balinese, unmarried, unemployed, and her symptom fluctuated between depressed feature, low mood, anhedonia, poor concentration, and hypomania traits such as reduced need for sleep and increased energy. She also experienced dizziness, headache, irritability, and physical complaint that raise suspicion of another medical conditioner. And her psychometry assessment show back depression inventory 18 and Hamilton depression rating scale 20 and Young mania rating scale 12, indicating mixed affective symptom. She had a confirmed diagnosis of polycythemia vera inherited from her father with elevated hemoglobin 18 and hematocrit 56, low erythropoietin. Bone marrow biopsy, hypercellularity granulopoiesis hyperplasia, draft megakaryocyte, and physical symptom, headache, dizziness, pruritus, abdominal pain, and splenomegaly. Meet WHO criteria for polycythemia vera. And clinical course about the 78 early exposure to her father, adulterous relationship, and then around 2005, repeatedly witnessed parental conflict and violence. And the 2060, parent divorce. Mother left the house. Felix chief discussed family issues public, and she felt bad father attempt suicide. And then 2017, father remarried. And 2020, diagnosis with polycythemia vera, then bipolar disorder. And 2021, she reported discontinuing both treatment, and then he not adherence and relapse with 6 months. This combination of trauma, mood instability, and medical compromise shape her clinical trajectory. And clinical challenges, there is significant overlap between symptoms of polycythemia vera and bipolar disorder. Polycythemia vera related fatigue and cognitive slowing can mimic depression symptom. Irritability from hypoxia or hyperviscosity can resemble bipolar mood instability. Her trauma history further contribute to maladaptive stress response, emotional dysregulation, and low resiliency. Relapse occur due to medication non-compliance, untreated polycythemia vera, and trauma-related trigger. Pharmacotherapy must consider thrombosis risk in polycythemia vera, potential metabolic side effect, and drug disease interaction, highlighting the importance of individualized treatment. Management required a multidisciplinary approach. Psychiatry was given valproate 250 milligram once daily and clobazam 10 milligram once daily, psychoeducation and adherent reinforcement, and trauma-informed approach. And hematology carry out the diagnosis and treatment of polycythemia vera to support mood stabilization, phlebotomy or cytoreductive therapy as needed, monitoring hematocrit to reduce hyperviscosity and improve neuropsychiatric symptoms, and consultant liaison psychiatry integration conduct to regular joint assessment, share decision making with hematology, consideration of trauma impact on coping, and adherence. The patient show improve after combined management. Mood symptoms were close tied to hematology, status, and recognized the role of polycythemia vera, clarified episode previously seen as poor psychiatry. And discussion, this case real triangular interaction among the childhood trauma is emotional dysregulation and vulnerability, and the bipolar disorder, mood instability, polycythemia vera, fatigue, irritability, cognitive slowing. This element amplify each other, creating a more severe and treatment-resistant presentation. Trauma dysregulated stress pathway and emotional control, polycythemia vera worsened cognitive and mood symptom through hyperviscosity and inflammation. This interaction highlight the need for holistic and integrated assessment, psychological, medical, and psychiatrist. Key point, childhood trauma significantly increase vulnerability to bipolar disorder. Polycythemia vera can mimic for or worsen mood symptom. Coexistence of bipolar disorder and polycythemia vera is rare and challenging. Trauma, psychiatric illness, and medical disease interact in a triangle pattern. Integrated multidisciplinary care is essential. Conclusion is this case demonstration how trauma history, bipolar disorder, and polycythemia vera interact significantly to create complex clinical symptoms. Early identification and integrated psychiatry, psychological, and medical approach are essential for meaningful recovery. Closing a history approach is not optional, is mandatory, is complex psychiatry. When trauma psychiatry, illness, and medical comorbid intersect, they cannot be treated in isolation. Thank you for your attention.
Buenos días, mi nombre es Carmen Carazo, soy docente e investigo en la Universidad Católica San Antonio de Murcia, de España, y les voy a hablar sobre la enorme diferencia que hay entre no rechazar la hipótesis nula y afirmar que es cierta.
Good morning, my name is Carmen Carazo. I am a researcher and a lecturer at the Catholic University of Murcia in Spain, and I'm going to expose this issue of the difference between not rejecting the null hypothesis and stating that it is true.
Y para esto no necesito recurrir al criterio de autoridad de ningún autor en particular, sino la lógica más básica que se impone cuando se comprende exactamente lo que es el valor P. Recordemos que el valor P no es otra cosa sino que la proporción de veces que ocurre el dato si la hipótesis nula es cierta. Por tanto, si el valor P es pequeño, indica que el dato es poco probable bajo la hipótesis nula y pensamos que es falsa, la rechazamos y decimos que no es cierta. Pero si el valor P es grande, el dato no es improbable bajo la hipótesis nula, por tanto, no invita a pensar que sea falsa. Podría ser cierta, como también podrían ser ciertas otras hipótesis que fueran compatibles con el dato. Es por eso por lo que la aceptamos como posible, la aceptamos como una posibilidad y afirmamos que puede ser cierta. Pero es muy diferente concluir que una hipótesis puede ser cierta a afirmar que es cierta. Y para darnos cuenta de ello, únicamente tenemos que usar en la ciencia el mismo razonamiento que usamos en otros ámbitos de la vida común, como veremos a continuación.
So to expose this problem, we are not going to use the authority of any particular scholar, but we are just going to use fundamental logic. We have to remember what a p-value means. So the p-value is just the probability of seeing the data that we have in the sample if the null hypothesis was true. So it's the likelihood of the data if the null hypothesis was true. If we have a small p-value, means that the data that we are seeing would be very unlikely to happen if the null hypothesis was true, and therefore we tend to reject the null hypothesis. We don't believe it's true. But if the p-value is large, the data could happen if the null hypothesis was true. However, that doesn't mean that the null hypothesis has to be true, because there could be other hypotheses that could also explain the data that we have in our sample. Therefore, accepting that the null hypothesis could be true is not the same as affirming that the null hypothesis is true. And we're going to explain this with more examples.
Veamos la similitud pensando en dos situaciones que son totalmente distintas. Vamos a pensar en primer lugar en un animal que hay escondido tras una pantalla. No sabemos lo que es y partimos de la hipótesis de que ese animal es un toro. Si nos dicen como dato que tiene alas, ese dato no es compatible con la hipótesis, por tanto rechazamos la hipótesis. Los toros no tienen alas y afirmamos rotundamente que el animal que hay tras la pantalla no es un toro. Pero si nos dicen que tiene 4 patas, ese dato es totalmente compatible con los toros. Todos los toros tienen 4 patas. Sin embargo, por tanto, no podemos rechazar la hipótesis, pero tampoco podemos afirmar que es un toro, porque son muchos los animales que tienen 4 patas. Por tanto, ese animal podría ser un toro, pero también podría ser cualquier otro cuadrúpedo.
Okay, let's see an example with common life logic. Let's assume we have an animal behind the screen there, and we don't know what animal is that. But we have this hypothesis that the animal might be a bull. If someone tells us that the animal has wings, then we say, okay, it's very unlikely, it's actually very improbable that a bull has wings. So we will reject our null hypothesis because the data is incompatible with the hypothesis. However, if we are told that the animal, instead of wings, it has 4 legs, then we will think, well, if it was a bull, it would have 4 legs. So the data is compatible with our hypothesis. So we cannot reject the hypothesis, but we cannot confirm it either because there could be many other animals that have 4 legs. So our data is compatible with our hypothesis and with many other hypotheses.
Ilustramos el mismo razonamiento en un caso de diagnóstico clínico. Vamos a pensar ahora en una mujer con un dolor abdominal agudo. No sabemos de dónde le proviene ese dolor y vamos a partir de la hipótesis de que esta mujer tiene un embarazo ectópico. Si nos dicen como dato que la paciente tiene 65 años, rechazamos la hipótesis porque las mujeres de 65 años no quedan embarazadas. Sin embargo, si nos dicen como observación, como dato, que la paciente tiene 30 años, ese dato es compatible con la hipótesis. Las mujeres de 30 años con dolor abdominal pueden estar embarazadas y tener un embarazo ectópico. Sin embargo, no podemos afirmar que ese dolor provenga precisamente de un embarazo ectópico. Podría ser que la mujer tiene torsión de ovarios, apendicitis o cualquier otra lesión que le produjera este dolor.
So let's see now an analogy with a clinical case. Imagine we have a woman that have an acute abdominal pain. And our working hypothesis here is that she's got an ectopic pregnancy. If we now learn that the woman is 65 years old, then the data is very incompatible with the hypothesis. A woman who has an ectopic pregnancy is very unlikely to be 65 years old. So we are very happy to reject the hypothesis. However, if they tell us that the woman is 30 years old, then a woman with an acute abdominal pain and 30 years old, that data is compatible with our hypothesis. So we cannot reject the hypothesis. But you can also see that that doesn't mean that the hypothesis is true, because there could be other hypotheses, other problems like ovarian torsion, appendicitis, or acute pancreatitis that could also explain the same data, a 30-year-old woman with an acute abdominal pain.
Y este mismo razonamiento, que es lógico y simple como estamos viendo, es el que usa la comunidad científica para interpretar el valor P. Vamos a verlo ahora en un contexto más científico, en un contexto de ensayos clínicos. Y para ello vamos a considerar tres ensayos clínicos, tres ensayos clínicos con tres tratamientos, el tratamiento A, el tratamiento B y el tratamiento C, en los cuales se intenta, en todo caso, por supuesto, estudiar la efectividad de ellos. Y para ello se compara el porcentaje de curados con estos tratamientos y el placebo. La hipótesis nula de partida en todos los casos es que el tratamiento, lógicamente, no es efectivo, es decir, cura exactamente lo mismo que el placebo. En el primer caso, con el tratamiento A, vemos que es muy efectivo, es claramente efectivo. Hay un efecto de curado muy importante, son 70% más de curados con el tratamiento que con el placebo. Este porcentaje es muy significativo. De hecho, es muy poco probable que bajo la hipótesis nula se diera una diferencia tan grande como la que tenemos. Así lo avala el valor P que tenemos aquí. En este caso, nuestro dato, al ser tan improbable bajo la hipótesis nula, permite que podamos rechazar la hipótesis nula con bastante rotundidad y la podemos asumir que ese tratamiento A, como queríamos demostrar, es efectivo. Bien, pensamos ahora en el tratamiento B. También es un tratamiento con efecto positivo. Como vemos, también curan más, hay un mayor porcentaje de curados con él que con el placebo. Una diferencia de 20 puntos, una diferencia de 20% que no es tan evidente como la anterior, pero que también es una diferencia moderada. En este caso, esta diferencia moderada no resulta significativo. El dato es compatible con la hipótesis y por eso no podemos rechazar esa hipótesis. Pero no rechazar esa hipótesis no quiere decir que tengamos que afirmarla. No podemos afirmar que este fármaco es inútil, porque de hecho podría curar incluso hasta 48% más de gente si se tomara ese fármaco que si se tomara un placebo, por ejemplo. Y por último, vamos al caso más extremo, el del tratamiento C. Este tratamiento C en nuestro estudio no ha tenido ningún tipo de efecto nulo, como así avala su valor P, lógicamente. Este dato es lo más compatible que hay. El dato es lo más compatible que hay con la hipótesis. Y en este caso, por tanto, lógicamente no podemos rechazar esa hipótesis. Pero aún así, en este caso tan extremo, no podríamos en ningún momento afirmar que el tratamiento es inútil. No, porque fíjense, si miramos el intervalo de confianza, todavía podría ocurrir que este tratamiento fuera útil, incluso que curara hasta un 26% más de gente que el placebo.
Okay, so let's apply this reasoning process to clinical trials because it's the same reasoning process. So let's imagine a clinical trial where we are comparing three treatments, A, B, and C, against a placebo, right? In each case, there is only 20 patients per arm, placebo and the three treatments. And in each case, the null hypothesis is that each one of those treatments is as effective as placebo. So no difference of the cure rate between the treatments and placebo. So let's look at treatment A on the left-hand side. And we see that placebo cures 20% and treatment A cures 90% of the patients. Now that difference is 70%. It's a very high difference. P-value is very small. That means that if the null hypothesis was true, if treatment A would cure just as much as placebo, then it would be very unlikely to see this even in a small sample as the one we have. In fact, the confidence interval goes between 48% and 92%, meaning that clearly treatment A cures more than placebo. So we would be very happy to reject the null hypothesis. However, moving on to treatment B in the middle, we see that treatment B cures 40%. So that's 20% more than placebo. Is double the cure than placebo. However, because it's small sample size, the p-value is 0.17. It's not very small. So this is telling us that if treatment B was as effective as placebo, that's the new hypothesis, if that was true, it wouldn't be very difficult to find a sample like this in a clinical trial. It wouldn't be very difficult to find a sample where, by chance, patients on treatment B would be cured 20% more than in placebo. Therefore, we cannot completely reject the null hypothesis because this sample could happen if the null hypothesis was true. However, that doesn't prove that the null hypothesis is true. You can see that, in fact, in our sample, we are curing more with treatment B, and the confidence interval gives a range from -8%, so that would be in favor of placebo, to 48% more cure with treatment B. So we cannot disregard also that treatment B cures more. It's just that we cannot disregard the null hypothesis. And on the right-hand side, we have the extreme case where treatment C in our sample cures as much as placebo, 20%, exactly the same effectiveness. So the difference is 0. Now the p-value is 1 because this data is perfectly compatible with our hypothesis. Is the most compatible data result with our hypothesis. So one will be very tempted to say our hypothesis is true, but no. We can not reject the hypothesis, but we cannot prove that it's true. We cannot say that we are proving that treatment C is the same as placebo, because there are also other hypotheses that are compatible with this result. It could be that treatment B could be even 26% better than placebo or 26% worse than placebo if you look at the confidence interval. So not rejecting the null hypothesis does not mean proving right the null hypothesis.
Y pese a la claridad de la lógica que estamos empleando, es común encontrar en la literatura científica errores en la mala interpretación de los valores P grandes en los ensayos clínicos y en los test de normalidad, por ejemplo. En el caso de los ensayos clínicos es común encontrar en la literatura científica que tratamientos como el B con un valor P que ha sido grande son considerados directamente inútiles y se descarta la posibilidad de usarlos, cuando podrían ser potencialmente útiles. Recuerden que podrían curar hasta un 48% más con ellos que con placebo. Y en el caso de los test de normalidad es muy común también usarse, que sean usados para comprobar la normalidad de los datos, cuando esto es imposible. Si el valor P fuera pequeño, lo que podríamos demostrar es que nuestros datos no son compatibles con ser normales, pero si el valor P fuera grande, lo que estaríamos es aceptando como posible que nuestros datos pueden distribuirse de manera normal en la población, pero pueden distribuirse así o no. En ningún caso los test de normalidad podrían ser usados para demostrar la normalidad de los datos. Lo único que podríamos conseguir con ellos es poder comprobar la no normalidad de los datos. Por tanto, se vuelve a hacer un mal uso del valor P grande, en este caso también.
So these are examples of how people are misinterpreting the p-value. For instance, in clinical trials, it's often we often see that people make incorrect conclusions when they have a p-value greater than 0.05. They assume that the treatment is ineffective. It cures the same as placebo, and that's completely incorrect. As we saw before, for instance, in the example of treatment B or treatment C, in particular in treatment B, replicated here, we can see that the treatment could actually cure 48% more than placebo. But because the p-value is not so small, people kind of decide that the treatment B is useless, and they might not continue pursue the research on treatment B that could be a potentially good treatment. Same wise, people misuse quite a lot the p-values to demonstrate, for instance, normality of a distribution. The normality test of the distribution has the null hypothesis that the data is normally distributed. If the p-value is small, we can reject that the data is normally distributed. But if the p-value is not small, we are not proving that the data is normally distributed. The normal distribution is just one of the possible distributions of the data, but there are other non-normal distributions that can also explain the same data.
Y la mala interpretación del valor P no es un error reciente, es un problema histórico, un error histórico. De hecho, ya en 1978, por ejemplo, Freeman ya nos decía que que había hecho una revisión de 71 ensayos clínicos que se habían publicado en la revista tan importante como es New England, en los que en estos 71 ensayos no se había podido demostrar que eran negativos, no se había podido demostrar la efectividad del fármaco y se había concluido que directamente era inútil, aunque en algunos de ellos el fármaco apuntaba a ser efectivo. Luego, esto, como vemos, es un problema histórico. También así lo recoge la editorial Nature, una editorial que escribe Nature en 2014. En esta editorial, Nature se hace eco del problema, argumentando que muchos son los médicos que no entienden lo que indica el valor P, y esto hace que se entierre la verdad científica bajo una avalancha de falsas conclusiones. Bien, también se hace eco de este problema Rothman en el 2021 y nosotros, nuestro grupo, en el 2024 también publicamos en la revista de Neurología un artículo con el nombre de la misma ponencia que tenemos hasta ahora, en el que ponemos de manifiesto que la correcta interpretación del valor P grande podría evitar abandonar líneas de investigación que podrían ser muy fructíferas.
Okay, so this problem has been mentioned from many years ago. It's not a new problem, and we have some examples there in some of the best medical journals: New England Journal of Medicine, Nature, European Journal of Epidemiology, a journal on neurology, where the authors have examined the problem. For instance, Freeman in 1978 looked at 71 negative clinical trials in New England, and in many of them they erroneously concluded that the drug being tested was useless just because the p-value was small, and that was the wrong conclusion. And so you can see that the problem has been standing for a long period, and even though the experts have been advising of how to use correctly the p-value, we still commit the same problems again and again.
¿Y por qué surge esta confusión? Pues principalmente por no distinguir entre los denominados test de significación y test de hipótesis. Son dos enfoques distintos de hacer inferencia de comienzos del siglo XX. Los test de significación, desarrollados por Pearson, Student y Fisher, tienen como único propósito adquirir conocimientos. En ellos el valor P sirve como una medida de evidencia en contra de la hipótesis nula. Ahí no hay hipótesis alternativa. Por otro lado, en los test de hipótesis, desarrollados por Newman y Pearson, tienen como propósito la toma de decisiones. En ellos siempre hay dos hipótesis, la hipótesis nula y la hipótesis alternativa. Y estos test están construidos para decidir cuál de las dos es cierta. Bien, esta idea fue desarrollada por estos autores en 1933, magistralmente en este trabajo, y tuvo gran repercusión. Y fue en 1956 cuando Fisher hizo una crítica sobre los test de hipótesis.
So this problem actually stems from long ago and is based on the confusion between test of significance on the left there, developed by Pearson, Student, and Fisher early in the 19th century, and in the 20th century, and the test of hypothesis developed by Neyman and Pearson later on the 20th century. The first tests of significance are not about deciding about two hypotheses. It's about accumulating information on one hypothesis, accumulating evidence against a particular hypothesis, right? While the tests of hypotheses are about deciding between two hypotheses, the null and the alternative hypothesis, right? So Neyman and Pearson published their method in 1933 in a very good paper that then was taken up by the scientific community and systematically misused as a scientific method, while in reality originally it was developed to make decisions more engineering method than a scientific method. And in 1956, then Fisher wrote a paper explaining how the test of hypothesis methodology was misused systematically for scientific research.
En particular, Fisher argumentaba en ese artículo que textualmente que hacia 1930 los problemas estadísticos que merecían tratamiento cuidadoso ya habían sido discutidos en términos del test de significación y que los test de hipótesis no eran más que un intento posterior de reinterpretarlos para tomar decisiones, aunque la toma de decisiones difiere en varios aspectos del proceso lógico que usa el científico que intenta conocer mejor la realidad. Esta importante reflexión fue también recogida en 1960 por Rosenburg. En este trabajo que aquí se muestra. Bien, en ese trabajo se decía literalmente, y con esta frase es con la que yo quiero acabar, que la tarea del científico no es prescribir acciones, sino establecer convicciones razonables, y que la creencia en una proposición no es un asunto de todo o nada.
So in his paper, what Fisher argued is that by 1930, all the statistical problems that deserve careful treatment had already been discussed in terms of test of significance. So test of significance had been used already to address the key scientific problems. And then later on, people have used tests of hypotheses to reinterpret these investigations by authors that had not participated in the development of the test of significance, right? So they have used a technology that was designed to make decisions to wrongly make inference to develop significance about hypotheses, right? And decision making, he stresses that decision making this differs in several aspects from the logical process of seeking a better understanding of reality. And Rothenbaum's in 1960 stresses this idea that the scientist's task is not to prescribe actions, is not to make decisions between these or that hypotheses, is to establish reasonable convictions. And belief in a proposition is not an all or nothing matter.
Y eso es todo. Muchas gracias por su atención y a partir de este momento quedo a su disposición para cualquier pregunta que puedan tener.
Thank you very much for your attention.
Good morning, everyone. I'm Davina Limbard, and it's an absolute honor to present before you today to share my vision, which has guided my life's work, which is human potential beyond neurons. My story does not begin in a clinic nor in a research lab, but it began with a child, a beautiful little boy who taught me that communication begins long before words. He showed me that healing doesn't always follow textbooks or our clinical trials. Sometimes it begins with just an eye contact, a shared smile, or a spark of connection through play. So over the past decade, through my work at Cognidan and at Brainability International, and the creation of NeuroPlay engagement method, as well as the NeuroHeal outreach program, I've had the privilege of helping over 2,000 neurodivergent kids find their voices. When I say voices, it doesn't necessarily mean only verbal, but neurological, emotional, and social as well. My approach integrates neuroscience, nutrition, and sensory repatterning with what I call as the neurocognitive play, where parents become healers and homes become the laboratories for transformations. This journey has led me from therapy rooms in India to government-led autism awareness campaigns in Dubai. And now I am here to share on this international platform where I hope to ignite a global conversation about how we see the developing brain. Because human potential cannot be reduced to synapses and scans alone, but it's orchestrated across our entire systems, sensations, and above all, love. And the next revolution, I hope, in pediatric intervention will not come only from technological advances alone, but it will come from connection, from parents who play to children who feel seen and heard. And that is what I mean by going beyond neurons, to awaken the full radiant spectrum of our human possibility and potential. So this presentation is called as Human Potential Beyond Neurons, a triad activation model for future-focused pediatric intervention. So let's step into an integrative system-based lens for unlocking the future of our children. For decades, neuron-centric thinking has driven our greatest advances, whether it's pharmacotherapy, advanced diagnostics, biopsychiatric models, etc. Yet, if we are really honest, pediatric outcomes have plateaued. Despite interventions all over and the advances, 1 in 5 children worldwide still continue to face persistent neurodevelopmental challenges. This statistic demands that we widen our lens. Are we looking too narrowly or maybe too locally? Maybe we should actually look systemically. So children, as we know, are not brains and vats, right? They are growing systems and they are all interconnected, whether it's the gut, the senses, the environment of social play, everything, every experience, shape, fuel, and scaffold the neural development. So the neuron cannot thrive in isolation. As we all know, an adult human brain generates around 700 neurons per day, primarily in the hippocampus, which plays a very important role for learning and memory. Though small in number compared to our existing neural networks, we know that given the right conditions, it can be influenced by learning experience, ecology, body, movement, and behavior. These new neurons will support the existing networks. But that means that a child's brain, which does not really produce any new neurons because they have existing billions of neurons which need to form neural networks. So it needs a lot of integration from all the life systems to build that strong neural network connection in their brain. This realization drove me towards a more comprehensive and integrative model while working with neurodivergent children. A model where brain potential is both dependent on and amplified by multiple life systems working together. When I first started working with children diagnosed with neurodevelopmental disorders back in 2015, what I realized was that almost all therapeutic models worked in silos. After a point, most outcomes that we were receiving were starting to plateau. And this is where, whether it was occupational therapy, speech therapy, behavior therapy, or special education. After working with over 100 kids, I realized that neurodevelopmental disorders were not a singular problem, but a multi-system issue, especially in autism. So after a lot of research on evidence-based interventions, I started to put together a comprehensive assessment and an intervention with whether it was nutritional and dietary profiling, which is with blood work and metabolic tests, sensory profiling, and social and adaptive tests to measure their ability to perform daily living skills, communication, socialization, use of motor skills, and as well as maladaptive behaviors. When I completed these comprehensive assessments for children, which I was working with, I discovered a sort of theme in their diagnosis. Almost 70% of these children showed signs of gut dysbiosis, and 85% showed sensory challenges from mild to severe. But what was most surprising was the outcome that these tests measuring adaptive and maladaptive behaviors, it was children who had both the gut dysbiosis as well as sensory issues who showed most maladaptive behaviors as well as signs of more severe cognitive challenges. So together with my team of therapists, we built the triad activation model, embracing the 3 pillars as co-drivers of child neurodevelopment. Gut health, which is nutrition, sensory integration with movement, and cognitive play, including behavioral interventions. Just to be clear, this model is not a replacement for neuron-based insight, but it is an extension, which is a systems activation framework where these pillars converge to unlock a healthier, more resilient neurodevelopment. So I truly believe that integration, not isolation, will create intelligence. So gut health, let's start with that. We call this the neurobiology's silent partner, because the gut-brain axis has been reshaping our entire understanding of emotional regulation and attention. Roughly, as we know, 70% of serotonin, central to mood and learning, is not really produced in the brain, but in the gut. So as mentioned earlier, dysbiosis in children is now being linked with attention disorders, anxiety, and cognitive delays as well. So our nutrition and dietary modulation with probiotic strategies showed measurable developmental gains when we used it with the kids who were with us. The gut is not merely for digestion, but it's a neurodevelopment's biochemical foundation. So the next pillar, which is sensory integration and movement, which I call as rewiring from outside in. Sensory integration and its essential companion movement. Sensory misprocessing is not just a symptom, as we know. It's often the root cause. Long before we see cognitive struggles, we see sensory chaos, whether from vestibular swings to proprioceptive play. Movement-based therapy re-regulates the entire nervous system. It primes the child's brain to receive and to respond. If cognition is the melody, I believe senses are the tuning fork. But here's the deeper truth. Before cognition, before speech, there is movement. And movement is the brain's first language. It shapes our neural architecture, it supports sensory regulation, and it activates executive function as well. Whether it's crawling, spinning, jumping, bilateral coordination, these are not just physical, these are neurological. And in the triad model, movement is not used as an afterthought, but it is embedded with every therapeutic step that we do, whether it's diagnostic, regulatory, or developmental. When children move with rhythm and purpose, their brains will synchronize with potential, is what we believe. And the final pillar is play. In psychotherapy, we use play as a therapeutic technique and the lowest level of abstraction. Hence, it is known to be mediator of change in a therapeutic setting. But play is not downtime. It is actually the neurocognitive re-engineering. Through free and structured play, the prefrontal cortex learns timing, inhibition, creativity, and social empathy. Yet, modern childhood, as we know now, is increasingly deprived of deep play due to the digital overstimulation. When, as clinicians, we reintroduced structured play-based interventions, we witnessed rapid strengthening of executive function and emotional resilience as well. To echo Einstein, play is indeed the highest form of research. So let me ground this in a child's story. We had a 5-year-old boy who presented with autism, nonverbal. He had severe attention deficits and frequent self-harming and aggressive behaviors. The child and the parents were frustrated with standard behavioral interventions, which yielded minimum gains after almost 2 years of therapy. When they first came to Cognidan, we introduced them to the triad activation model, and we explained to them how it works. So after a comprehensive assessment of blood, metabolic panels, sensory and motor assessments, and other assessments that we did, we started with the microbiome support and nutrition program with obviously probiotics to enhance their nutrition and digestion. We also provided them with a personalized sensory diet with rhythmic movement sessions and structured play therapy to enhance executive functions. Now, within the first 6 months, we actually noted more than 30% improvement in their executive functioning scores. Teachers, in fact, this was COVID time, so even his teachers, they used to have virtual classes. Earlier, he didn't pay attention at all, but teachers reported sustained attention even before virtual classes, and parents reported emotional stability at home, especially a lot of reduction in self-harming behaviors that he earlier showed. And the child also regained joy in learning. He used to be not curious at all before, but he started enjoying various things, and he started becoming curious about things around him. So this is not just a treatment that we are talking about. This is a transformation through systems activation. But that requires looking at all life systems rather than just working on silos, on just one aspect of a disorder or a challenge. So moving on, let's look at data, and let's look at what happened through this data. So here are certain sensory factor scores from the child's case. Just give me a moment. So these are actually the before and after. So in 2019, when the child, we started his entire comprehensive assessment, these was the child's scores when he actually was presented to us. Whereas he actually showed definitive differences in inattention, poor registration, and emotional reactivity. But by July 2020, when we reassessed him on the same parameters, we saw that almost all his various factors were showing typical for age. Even though there was a drastic change, there was obviously a lot more progress yet to come, but we did see drastic changes in almost every factor that we looked at, whether it was modulation for movement, or whether it was oral sensory processing, multisensory processing, or even emotional social responses that he would have during sessions with us, as well as outside with his parents. So this shows that how addressing internal systems and the environment completely, so the inside out approach, this has reshaped our understanding and his sensory regulation and response. This is the second, just give me a second. Yeah. So this is the other, sorry about that. Just give me 1 second. I'm sorry, I am, my screen is stuck. Can you give me a moment, please? I'm just going to stop sharing for a minute and I will reshare. Is that okay, Claire?
Okay, Dr. Javina.
Thank you. Right, can you see my screen?
Yes, doctor.
Okay, thank you. So I'm sorry about that. So from multisensory processing to emotional tone and social responses, you can see that the changes were consistent throughout the domains and across domains. So every category that we initially saw, whether it was probable difference or definitive difference, returned as typical for age after the triad-based intervention that we did. So the sensory system, no longer had any bottleneck. In fact, it became an enabler for the child to learn and progress and grow. This is the the quadrant classification, which shows the kind of emotional reactivity, the low endurance tone, inattention, distractibility, and other things that were flagged when he first came to us. And then after almost 6 to 8 months of therapy, you can see the kind of difference that it showed with the same factors. So that, like I said, in 2019, the child was flagged in all 4 quadrants for registration, seeking, and everything. But you can see that in 2020 July, he shows typical for age, which means that a lot of his challenges started reducing over time. Whether it was seeking, sensitivity, avoiding, everything was moving towards typical for age. Just a moment. I'm sorry, it's for some reason my computer is getting stuck. Just a second. Right. So, okay. So, yeah, so.
Distinguished guest, allow me to begin with a quote. Be the person your dog thinks you are. This perfectly captures one of the core ideas behind why we integrate canine-assisted interventions at our psychiatric department. My name is Sergej Bodnar, and I serve as the head psychologist at the psychiatric department and the psychiatric hospital in the small town of Trebišov in eastern Slovakia. Today, I will present our experience and one of the studies we conducted. So first, we will briefly clarify the terminology, as several forms of canine-assisted interventions are distinguished in practice. Next, I will outline the legal and procedural conditions that allow us to implement canine-assisted activities within hospital settings. After that, we will focus on our research design and its outcomes. And finally, we will conclude with an opportunity for discussion. Returning to the quote, dog does not judge, does not evaluate, dogs love you. This is not new, because one of the earliest confirmations of the human-animal bond is a burial site of human holding a puppy, dated approximately 12,000 years into the past. Dogs assisted persons with disabilities as early as the 9th century, helping people manage their difficulties. Human-dog relationship has evolved from domestication. Initially, dogs were used for guarding. Later, they served as herding dogs, and today they are indispensable in police work. Now, in modern society, dogs are often considered family members. It is therefore not surprising that their role expanded into healthcare. Their use, however, varies widely from education, activities, therapy, intervention to crisis response, as you can see with description at every one of them. And since canine-assisted therapy is not legally recognized in Slovakia as a formal treatment modality, we decided to implement animal-assisted activities. These were incorporated as a therapeutic method, and after completing all necessary administrative steps, we successfully introduced canine-assisted activities at our psychiatric department. We also selected animal-assisted activities because it allows us to include a broader range of patients with diverse diagnoses. Naturally, all types of canine-assisted interventions overlap to some extent, educational and therapeutic. Educational and therapeutic elements can be found even during animal-assisted activity sessions. And as you can see, to protect personal data and medical confidentiality, the photograph display only staff members. Here, my colleague, here, am I here, and this is our canine-assisted practitioner. And here in the background, you can see patients. And you can observe two environments in which the activities take place, the indoor gym and the psychiatric park adjacent to our building, used exclusively by our department. And you can also notice a moment where the supportive message on the dog collar happens to match the patient's t-shirt. Here, never give up, and t-shirt of one of our patients with the same writing. When the weather is warm, we conduct canine-assisted activity outdoors. During cold or rainy days, sessions are held in gymnasium located on the ground floor of the psychiatric hospital. Here is our gymnasium, and this is our park. As you can see, this is our building. Because activities are group-based, we collaborated with our external canine practitioner to optimize the structure, pace, and engagement of participants. This was conducted by our multidisciplinary team, and this resulted into identifying 10 patients as the ideal group size. Canine-assisted activities were integrated into our existing therapeutic program and scheduled every Wednesday, which has remained unchanged for 6 years now. They function alongside virtual reality exposure therapy, repetitive transcranial magnetic stimulation, group psychotherapy, art therapy, and many others. All procedures were proceeded by protocols, informed consents, risk assessments, evaluations of the dog's health, patient's health conditions, and safety planning. We also considered each patient's current state, mobility, and psychological suitability, which is determined collaboratively by multidisciplinary team. If a patient is immobile, our staff prepares the room to allow for bedside visits by the canine practitioner. Patient selection is based on diagnosis and functional capacity, always in consultation with the practitioner. Patients with anxiety and depression receive more experience-focused sessions, while those with, for example, mild cognitive impairment or dementia participate in more activation-oriented activities. In both cases, each session begins with an introduction, basic commands, and explanation of the procedure. Before the main study, we talk about this. So, before the main study, we conducted a pilot study with 15 participants across various diagnoses. We used the qualitative research design, specifically content analysis, based on semi-structured interviews. The most frequently reported feeling was calmness, followed by joy. Patients demonstrated improved engagement in group therapies and enhanced interpersonal functioning. And the experience offered them a meaningful topic to communicate about, enabling them to share, open up relatives and staff, and ultimately support other patients during group sessions. For the main study, we embraced the idea that simplicity is powerful. So we therefore use the back depression inventory tool, administered 2 days after admission and 2 days before discharge. The instrument is simple, comprehensible, low burden, and psychometrically strong in detecting depressive symptomatology. The study included 97 patients divided into experimental group, which received canine-assisted activities, and control group, which did not. But both groups received identical standard treatment methods. We aimed for the highest possible homogeneity. Therefore, diagnosis and pharmacological treatment were matched. Our sample consisted of 49% of men and 61% of women, with a mean age of 49 years. The primary objective was to evaluate whether adding canine-assisted activities yields measurable clinical improvement. And as you can see, we have two figures here. But since the groups differed in their initial BDI-2 scores at admission, we applied an analysis of covariance, which extends ANOVA by including elements of linear regression. For sensitivity analysis, we use both frequencies and Bayesian approaches. After controlling for baseline BDI-2 variance, results confirm a statistically significant difference between experimental and control groups with a substantial effect size. Both groups improved, but the improvement was significantly greater in the group receiving canine-assisted activities. After all that, we saw the improvement, as I said earlier, in group sessions, which for us was great because their health, their state of health was better every day. So we can therefore conclude that patients whose treatment plan include canine-assisted activities showed significant clinical improvement. Beyond statistical evidence, these patients also reported enhanced social interactions and resurfacing of positive memories. And you have data here, but a small anecdote to conclude. After participating in canine-assisted activities and later in virtual reality exposure session featuring the Aurora Borealis in snowy mountains, one of our patients enthusiastically shared this with his family, every experience which he had in that day. And the family immediately contacted us, concerned that his mental state had deteriorated, as he claimed he had been with dogs and then he watched the Northern Lights. So it took quite some time to reassure them that in fact his condition had improved and there was nothing to worry about. So thank you for your attention.
The prevalence and determinants of burnout in a Moroccan company. I will begin with introduction, then material and method, then results and discussion, and I will finish with conclusion. Sorry, I have a problem. Burnout or professional exhaustion is the pain of the century. It results from chronic work-related stress. It is a professional syndrome characterized by emotional exhaustion, negativity toward work, or cynicism or depersonalization, lack of personal accomplishments. Burnout carries significant costs, both to societies and to human well-being. In the European Union, burnout and stress cost more than $300 billion a year. According to a literature review on psychosocial risks in different sectors in Morocco, burnout is the psychosocial risk that manifests itself the most, with a prevalence of 49%. In our study, we will assess burnout and its components and examine the socio-professional determinants among employees. For material and method, the study setting is an industrial Moroccan company located in Kenitra. The sample size was 102 voluntary employees. and the interview method was direct in workplace, and we used /burnout inventory and other question, but we will focus in this presentation at results of MBE. And we have used SPSS software for analysis, statistical analysis. For data interpretation and measurements, the table shows the score modalities. There is burnout if the level is pathological for at least one of the three components. A pathological level in only one of the three scores defines a low level of burnout. Having two pathological scores out of three makes it possible to speak of moderate burnout. A high score on two of the first components and a low score on the last indicates a high level of burnout. For results and discussion, the age of participants was between 20 and 40 years old for 66%, and 34% of the participants are 40 to 60 years. For gender, we had 76% of male and 24% for female. For marital status, we had 67% are married, 2% are divorced, and 31% are single. 42% have 1 to 2 children, 18% have 3 or more children, and 40% don't have any. For the school level and professional status of interviewees, we have 30% of the participants are more than baccalaureate +2, 50% have baccalaureate to baccalaureate +2, and 20% have less than baccalaureate. For professional status, 20% are senior manager, 48% are technician supervisor, and 32% are executing worker. For results and discussion, 42% of our population are exhausted. Among those, 34% have low level of burnout, 7% have moderate level of burnout, and only 1% have high level of burnout. For the other studies, we note that 49% among Moroccan employees in different sectors are exhausted, and 82% among Indonesian health workers, and 18% among Swiss workers. For competence among exhausted subjects, we have 46.5% have high emotional exhaustion against 22.1% among Indonesian workers. 30.9% have high depersonalization against 11.2% among Indonesian workers, and 27.9% have low personal accomplishments against 29.4% among Indonesian workers. So the most common component of burnout among exhausted people in this population is high emotional exhaustion. For burnouts and age and gender, as this table shows, the rate of burnout increases with age and among men, but no corresponding significance was found. For burnout and school level, the rate of burnout is high among people having school level between baccalaureate and baccalaureate +2, but no corresponding significance was found. For burnout and professional status, the rate of burnout is high amongst supervisors, but no corresponding significance was found. For burnout versus seniority, the rate of burnout is high among people having total seniority between 10 and 20 years, and seniority in the company more than 20 years, and seniority in the position less than 10 years, but no corresponding significance was found. For burnout and marital status and number of children, the rate of burnout is high among married people and people who have no children, but without significance. For burnout diverse symptoms, burnout is significantly linked to consuming alcohol or cigarettes or both. For high level of emotional exhaustion, it decreases with age, hierarchical level, total seniority, and number of children. It is high among men and married people for results of the other studies. But for our study, we don't found significance, any significance link. For high level of the personalization, the high level of the personalization increases with school level, hierarchical level. It is high among women, total seniority less than 10 years, seniority in the position more than 20 years, and single people, but without a significant link. For a low level of personal accomplishments, it is high among men, but without a significant link. In the conclusion, the study confirms that burnout is present within the employees of the company. Object of our study, the most common level is the moderate one. The most common component of burnout is emotional exhaustion. The variation in the scores of the components of burnout for our population is consistent with the results of the majority of studies on this subject, even if no significant link is found. The determinants identified in this study are gender and professional seniority. They particularly influence depersonalization. To improve the results, sample size needs to be increased. Thank you for